All right. Good evening, everybody. We'll get going from here. Again, I want to make sure that, especially for the recording people, that take a look at the Facebook post and posted 4 questions on there that I'd like for you guys to comment on. I would like to see more than the same 4 people, 5 people comment and answer questions. So let's see if we can do that. On an average, we get about anywhere between 15 and 19 people. I'd like to at least have 15 to 19 submissions. It kind of teaches us all, gives us all opportunities to ask each other questions and really just make sure we're all on the same page. All right, so I want to make sure I added a video, and I think this is kind of a good video. It kind of breaks everything out. So as this plays, somebody just make sure that you give me like a thumbs up or just a one-letter response, making sure that it works.
All right, I want a 12 lead on 2 lines. Let me get a sugar. All right, man, I got a 20 gauge in the left AC. 20 gauge left AC. I mean, I would have got an 18, but it's whatever. You guys ready to go? Oh, yeah, just give us 1 second. All right, copy, let's go. Listen, compression depth is 2.4 inches. You're going 2.3. I need you to go a little bit deeper. Do you think my chest is hurting because I'm having a heart attack? Well, if you are having a heart attack, then the cells inside of your heart are dying, exploding, and releasing something called troponin, which, left uncorrected, will eventually lead to cardiac arrest and your inevitable death. Why are we going to so many calls? Because it's your job. Hey, brother, truck's good to go. That sounds good, bro. Seriously? Listen, I'm never missing innovation, and if I ever quit, this entire place will crumble. Dude, I've been here long enough, man. I don't even need to go to medic school, bro. I know all the skills that they do. And when I do go, I'm going to smoke it.
All right, so that kind of brings up to the point is,
All right, I want a 12 lead. 20 gauge left AC.
If I could hit the right button. All right, so
all right, I want a 12 lead.
Go. All right, so that just kind of breaks out everything that you're gonna see. If you've ever worked in EMS before, everybody knows that guy that we're referring to or that girl. Just kind of gets a little funny. Tonight's gonna be a little deep, and I'm sorry for that. We're not trying to confuse everybody, but there's a lot when it comes to cardiology that we got to go over. Hopefully, I've inserted another video in here that will break it down and explain it a little bit. I liked it. I thought it was a really good choice. Not just saying that because I picked it, but I thought it was a really good explanation of what we're going to go over and kind of give you a little bit more in depth. There's a pretty good bit of slides on here too, so we're going to try to make this work. All right, so we're going to go over the pathophysiologies, the fundamental knowledge of pathophysiology of respiration and perfusion of the patient, assessment and management during a cardiac incident. Some medicine. So medicine, we've talked about this before, is a fundamental knowledge to provide basic emergency care and transportation based on the assessment findings of an acute ill patient. So cardiovascular, get these out of the way and we'll start going from there. It's anatomy, signs, symptoms, and management of chest pains and cardiac arrest. We're going to do anatomy, physiology, pathophysiology, assessment and management of acute coronary syndrome, angina pectoris, myocardial infarction, and aortic aneurysm or dissection. We're going to go over the management of thrombolisms, heart failure, hypertensive emergencies. All right, so now we can kind of break it down a little bit slower because the first part's always boring to me. So the cardiovascular disease has been the leading killer of Americans since 1900s, which we know that because everybody preaches about that, but at the end, nobody ever really wants to go make sure that they're healthy, and about 1 in every 3 deaths are cardiac related of some sort. So the EMS can help reduce these deaths by doing some of the by encouraging healthy lifestyles, which not every EMS person has the best healthy lifestyle. I mean, we all can point fingers at each other, but just remember when you point, you got 4 other fingers pointing back at you. Early access to medical care. Let's not delay the patient. Let's get them to their most appropriate place and the right amount of time. Always try on more CPR training for lay people. That's why a lot of agencies will talk about doing CPR for bystanders. No, it's not a certification, but it helps our job in the long run. Then you do increased use of evolving technology in dispatch and cardiac arrest response. And that goes all the way down to EMD, which is emergency medical dispatchers, which is, from what I've been told, is a very complicated class, rather than just a regular dispatcher. So technology and helping us get there faster, GPS, all these things can help us improve these results. So we're going to talk about also EMS can reduce also continued public access to defibrillation devices. A lot of malls are putting those in there. A lot of companies are doing the same thing. They have dropped drastically in prices. I remember when they first came out, they were like 10 grand a piece just to put it, like a individual or a business owner grab buy them, and they were about 10 grand each. So it was very expensive. Recognizing need of advanced life support and the use of cardiac specialty centers, and that's what we know. We know we need to take somebody to a cardiac specific facility because of we work in the area, we know the environment, and now unfortunately due to COVID, we're always busy. Every hospital is busy, but if it's specialized for that patient, let's get them there. All right, now we're diving off. I'm not gonna tell you how many more slides, but I'm gonna keep it clicking tonight. So the heart's job is to pump the oxygen enriched blood cells to the tissues of the body. The heart is divided down the middle and to the left and right sides. I wish I could. I'm talking on my hands, and I hope maybe one day I'll turn it back on and let y'all see. It's a little bit easier to understand. But the pictures coming up, I think it'll help it. So each has a upper chamber, which is going to be your atrium, and it receives the incoming blood, and then the lower chambers are the ventricles, and that's the pump outgoing blood. So the upper chambers take the blood, the lower chambers push the blood. So your atrium and ventricles. All right, everybody there so far? Good. So there's big pictures. We're going to talk about your Vena Cava tonight, how the blood goes in, where it goes out of. The video I attached, I promise you, it's going to make it a whole lot smarter than probably the way that I can explain it to you folks. There we go. So one-way valves keep the blood flow, which y'all know we have one-way valves. The same thing in our veins keeps the backflow of pressure going down one way. You've always heard that medics saying, "Oh, I can't stick there because there's a valve," or "I stuck right before, like I'm touching the valve. I got to float it in by give me a cc of normal saline." So it's a preventer. It's the same thing in the fire service. They have one-way valves, check valves. If anybody knows about sprinkler systems, they're the same way. So the aorta is the body's main artery, which receives blood, is ejected from the left ventricle and delivers it to all the other arteries that are supply the body's tissue. Yeah, I know that's a lot. I promise. Look, let's check out this picture right here. So, whoop, wrong mouse. Sorry, guys. So the supravena cava right here is oxygenating poor blood from the head and the upper body. So see how it comes in? All right. So then the right atrium right here at the top. So the inferior vena cava is going to come in here. So this oxygen poor blood. So it's coming in here also at the bottom. The right ventricle, we talked about that. That's going to have oxygenated blood. And then you'll have going to your left pulmonary artery, which is blood to the left lung. Same thing on the right side. It's just flipped over. So now it's coming in from right here on the sides, and then we're going to put it out on the other side too. It's the same thing. They pump in all different motions, but we're going to break it down a little bit deeper as we go. So I know some folks had some issues when it talked about respiratory. I do expect some issues when it comes down to this cardiac chapter. It's a lot. So please don't forget, if you need me, please direct message me, Facebook, or I'll post my email on there also that you guys can hit me up. All right. So anatomy of the physiology. So a heart's electrical system controls heart rate and coordinates the work of the atria and the ventricles. So that right there gives us our pulse. So the heart generates its own electrical impulse starting at the sinus node. So without going into EKGs and all that fun stuff, you can see that. If there's no electrical movement in the heart, that's where you get flatline. That's where you get asystole. Well, that's what we want the heart to pump on its own. We don't want to have to put electrical in it. It's easier when people are doing it on their own. The impulse passes from the atrium to the ventricles, and then it says automatically allow spontaneous contraction without stimulus from the nerve source. So that's what we were talking about, like the brain automatically makes the body breathe, which is super cool. And then now the heart's doing on its own without us having to think about it. So we're building up. Imagine if we had to think about breathing and our heart beating at the same time. Not many of us can chew gum and walk, so just remember that. All right. So it automatically allows spontaneous contraction without a stimulus from any of the nerve source, like I said, as long as the impulse comes from the the SA node. Whew, that one got me. The other myocardial cells will contact when the impulse reaches them. There's a picture that's going to make it out a little bit better in a second. So if there's no other impulses, no other cells are capable of creating their own impulse, so it's only coming from the SA node. So just remember that. The electrical parts come from the SA node, and that's the most important part that we got to remember because that's where the electrical starts. All right, so you see right here, goes to the SA node to the AV node. All right, so that's the functionality of the heart. So here's our passages. So just round and round and round. Okay. All right. Whew, I know this one's going to get deep. So the autonomic nerve system, which is the ANS, controls involuntary activities of the body. We talked about this earlier in respiratory, how it controls its own parts also. So the ANS has two parts, which normally balance one or another. The sympathetic nerve system, which is your fight or flight system, which also speeds up the heart rate, it increases respiratory rate, and the depth dilates blood vessels in the muscles. So, and contracts blood vessels in the digestive system. So it's automatically working all the time. So your fight or flight systems go in there. In times of stress, the system takes control. So then we go over your parasympathetic. So your parasympathetic nervous system slows the heart rate and the respiratory rate. It constricts blood vessels in the muscles and it dilates blood vessels in the digestive system. Of relaxation, this system takes control. So when we're up and moving, we're getting going, we're all flexing throughout the day, your fight or flight method is going to happen. I don't know if anybody's ever been in a situation to where you get that dump of of your epinephrines, and then you turn around and you're all worked up, and there's certain things you're not going to remember, or you'll lose some fine motor growth skills. That's what we're talking about there. So that's your fight or flight. And then when you go to rest and you lay down, you swap over to your parasympathetic nerve system. So that allows you to digress, sleep, and function in your sleep. So if you always worked off your fight or flight, it would be very, very hard for us to sleep because we're always wanting to go. We're having that dump of epinephrines. So thank God we have these two because a lot of us couldn't sleep. Um, so the myocardium, it must have a continuous supply of oxygen and nutrients to pump. Other than that, we in trouble. So increased oxygen demand during periods of physical exertion is supplied by dilation of the coronary arteries. So like when you're in exercise or you're in the gym or you're on a serious or what we say as a hot call, you're going to get this dump. You're going to get the increased oxygen demand. You're not going to realize your respiratory rate's increasing, but now you understand a little bit why it's happening. So for stroke volumes, we describes the volume of blood ejected with each ventricle contraction. Increased stroke volumes result in increased cardiac output. So the more cardiac output that we have, the more chances we have for a stroke. That's the reason why we always check about these blood pressures. Ooh, that's a high blood pressure. You know, you're at a stroke level. No, we don't want to scare the patient, but at the same time, we want to be honest to them. So just remember that. All right. Questions so far? I know we're not that deep, but any questions so far? I'm gonna take that as a no. We're gonna keep rocking. All right. So, all right, Robin. Nah, I'm good with you too. I know it's a lot. I'm sorry. All right, so the coronary arteries are the blood vessels that supply blood to the heart muscle. So we talked about that. So that's coming from an artery. They're going to start telling you the difference between arteries and veins. So the right coronary artery supplies blood to the atrium and the right ventricle, and in most people, the inferior wall of the left ventricle. That's very confusing. Very. I can go ahead and tell you. The left coronary artery supplies blood to the left atrium and the left ventricle and is divided into two main branches just a short distance from the aorta. How about this? Let's look at this picture. So we're going to talk right here. Here's your aorta. Here's your supravena cava, your right atrium, your right coronary artery. So all this is going to pump on here, and then your SA node is all right up in here. Remember we were just showing your electrical components? That's what makes this work. All right. So you're going to your lungs. It's the main coronary artery, which is right here. See the little red line back in there? Now, I'm not asking you to diagram and color me a picture, really pretty picture of this of the heart. It's just something I want y'all to look out to. So now we're going to talk about some of the arteries supply oxygen to different parts of the body. The right and left cricoid arteries supply the head and brain. So the right and left subclavian arteries supply upper extremities. The brachial artery supplies an arm. Does everybody kind of know where each one of these veins are? As y'all are sitting here looking at that, as I'm reading over and kind of giving y'all some ideas, do y'all know where some of these vessels are running down? Yep, I see Victoria's on it. Anybody else? I think there's some diagrams. All but one. Which one is that, Travis? Don't worry, Robin. I figured some of them too. You sit here and I go over this and it's like, I don't remember where that's at. All right. So we'll go, Travis, in just a second. When I hit it, I'm going to make sure as soon as I say it where the iliac arteries go, you're going to be like, yeah. I just didn't know what that was called. All right. So they talked about the subclavian, the brachial arteries, the radial and ulnar arteries supply the lower arms and hands. Now, here you go, Travis. The right and left iliac arteries supply to the groin, pelvic, and leg. And then the right and left femoral arteries supply to the legs. So we're probably thinking about, Travis, if I'm with you, you're probably going on the iliac, you're kind of thinking about the femoral. So that's the same area. You hear it more of a femoral than you hear the iliac. So the anterior and posterior tibial and the peroneal arteries supply the lower legs. That's where so a lot of places will go and do heart caths in the legs. They'll go through the groin right there in the area, not technically in the groin, but then femoral arteries. So that's kind of a little place that kind of triggers in our head. All right. So arteries and capillaries are similar vessels. The capillaries are one cell thick. That makes sense to anybody that's ever had a A&P before. They exchange nutrients and oxygen for waste at the cellular level. Super important. They connect atrials to the venules, which is digging down even smaller. The venules and the veins receive blood from the capillaries. The venules are the smallest branch of the vein. I would kind of like, I don't know if y'all can hear me knock on that one. That might be something you want to write down. The vena cava returns oxygen depleted blood to the heart. So remember that. So the vena cava returns oxygen depleted blood to the heart. Supravena cava carries blood from the head to the arms to the back of the right atrium. So, man, these vessels are all over, and I'm sure y'all are going, what's he saying? Let me get to the video. I promise you it makes a lot of sense to you. It'll break it down, and you'll get a better idea. So the inferior vena cava supplies blood to the abdomen carries blood from the abdomen, kidneys, and legs back to the right atrium. So you have your upper vena cava and your lower vena cava, which is your super and inferior. So that kind of you can figure out which one goes to there. Is your superior vena cava is all your arms in the back. And then the inferior are everything lower. How about that? Is that better for you guys? So blood consists of several types of cells. You got red blood cells that carry oxygen and they take carbon dioxide away. Your white blood cell count, that's really big if you start to get infections. They help fight those. So if you got a high WBC, you know that you're carrying an infection. Platelets are a huge one because if you're low platelets, you're not gonna be able to clot. That's a lot of people that are low on iron too, don't have a lot of platelets. Plasma is all that little clear fluid that all the cells float in. So kind of so you'll understand a little bit more about the blood. All right. So the blood pressure is the force of circulation of blood against the artery wall. So what that's telling us is if there's a lot of pressure in there, it means the heart's under stress. So with the under stress, the blood pressure is going to go up. As you can see, the maximum pressure generated by the left ventricle. So that's the reason why we want to keep that blood pressure low as possible, so that doesn't put the heart under stress. So systolic blood pressure is the maximum pressure generated in the arms and legs during contraction of the left ventricle during the times known as systole. I'll go over that a little bit more. That's probably everybody's like, I don't really care. So somebody tell me what is systolic, diastolic, which one is the top number in the blood pressure reading between systolic or diastolic? Systolic is the top, right, Victoria and Travis, that's a good one. So the diastolic pressure is against the artery walls on the left. So you got your systolic is in the contraction, but the diastolic is on the pressure against the artery walls on the left ventricle also, which we all both said. So now y'all know where the top and the bottoms are. So anatomy and physiology continued. I know it's gonna keep going. So a pulse is felt when it passes through an artery during a systole. Then during systole, the peripheral pulse are felt in the extremities. You talk about radial and posterior tibia. That's kind of hard to find in my opinion, but we'll show you in just the next picture. And your central pulses are felt near the trunk of the body. So what that's going to do is you're just going to show your femoral, your cricoid pulse. And here's some pictures. If nobody's ever looked at now, so here's your posterior tibia. I'm always going for your dorsal. To be honest, I've always looked here. I've never felt on the inside. It's just a personal thing. We all know radial. Brachial can be very, very hard to find sometimes. So if you find it, most of the time that may be a traumatic issue to where they're pumping blood and you start to see squirts. That's probably going to come from right here in your brachial area. In your femoral, that's going to be deep inside the pelvic girdle right here between where the legs and the pelvic bone meet. Be very, 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 very cautious when you go to check that. You don't need to check it on every single walk-in medical call that you go to. You need to justify why you're checking a femoral pulse. If it's traumatic, that's fine, but not on grandma that fell and broke her hip. Travis, to me, femoral and brachial are the hardest to find and feel. So I will say the brachial to me is very hard. I guess, unfortunately, I've done it so much in my career. I've been blessed to learn a lot by mistake, and I held a black cloud over my head for a very, very long time. But I like to check for femoral pulses in a traumatic incident. The reason why is they're big. They have a lot of blood flowing through there. So if you push in the right spot and hard enough, you'll feel it. So we know this one right here. We all know these two, all of them. Now, what's the number one thing that you see in this picture that they're not doing? Anybody want to guess where I'm going? They're not using their what? Correct, Victoria. They're not using their thumb. Does anybody want to elaborate besides Victoria on why they're not using their thumb? Taking the pressure off of you, Victoria.
The thumb has a pulse itself.
Get it, girl? Get it. Thank you so much. I appreciate that. So the pulse itself has, thank you, Travis, too. You can think that it is yours. And you're like, oh, I feel it. No, because you feel yourself. You're like, oh, they're 101. Maybe that's your pulse because now you're trying to figure out if grandma, why she got 101 pulse, but she blue. It's you, bro. So anyway, good point on both of y'all. Thank y'all for that. That was very good information for y'all to key in. All right, so the cardiac output is the volume of blood that passes through the heart in a 1 minute span. Y'all feel me on that? So your cardiac output is how much blood that you push out in 1 minute. So that's calculated by multiplying the heart rate by the volume of blood ejected with each contraction, which is also called the stroke volume. So in the field, stroke volume can be roughly determined by the heart rate and the strength of a patient's pulse. Bro, I'm gonna tell you, I've never figured that out in the field because I don't have time. But that's great information. Perfusion, is the constant flow of oxygenated blood to the tissues. Good perfusion requires the following: a well-functioning heart, an appropriate heart rate allows proper volume of blood to be circulated. Then you got adequate volume of fluid and or blood. Now there's a difference, and we'll tell you in a minute. Reduced volume, so that you reduce through hemorrhaging, limits the amount of tissue that can be perfused. Then you got blood vessels must be appropriately constricted to match the volume of the blood available. If you ain't got enough that's working, that's open, your pressure is going to be high. Dilated blood vessels may mean reduced perfusion, and if perfusion fails, cellular and eventually the patient's death occur. So the reason why I said fluid or blood, because sometimes you can have a plasma-like substance running through the body, which is what we call LR, lactated ringers, that or some agencies are now starting to carry blood and or plasma on their ambulance, which is a very excellent thing, but that's very expensive. So you're looking about 10 grand a bag, but we can carry that in the field now, and that tells you how far that EMS has gone. Several agencies started with air medical transport having that, and then it went on to critical care, and some ambulance services are allowing that. So here's the video that that I was telling y'all about that I really like. This is brought by she's a peds nurse. She'll introduce herself in a second and what hospital she's at, but it breaks it down. So it's the basic cardiac anatomy and physiology by this pediatric nurse, and I think she does an amazing job. So I think this video is like 6-7 minutes long. Again, if y'all don't mind when it's playing, just somebody let me know that it's working right. Because I'm gonna mute my mic, and I'm gonna step away and turn down the big mic that y'all hear in the background. So I want to make sure it's playing before I get off of here.
Basic Cardiac Anatomy and Physiology by Nancy Broaddus.
My name is Nancy Broaddus, and I am a clinical nurse specialist at Children's Hospital of Boston, and I will be going over cardiac anatomy and physiology.
Normal cardiac anatomy.
The right side of the heart receives venous blood from the body through the superior and inferior vena cava, which enter the right atrium. Blood flows through the tricuspid valve into the right ventricle. Blood leaves the right ventricle through the pulmonary valve into the main pulmonary artery. The pulmonary artery divides into right and left pulmonary arteries to transport deoxygenated blood from the right side of the heart to the right and left lungs. The pulmonary arteries branch further into the pulmonary capillary bed, where oxygen and carbon dioxide exchange occurs. The 4 pulmonary veins, 2 from the right lung and 2 from the left lung, carry oxygenated blood from the lungs to the left side of the heart. The oxygenated blood flows from the left atrium through the mitral valve and into the left ventricle and out through the aortic valve and into the aorta and to the body.
Cardiac valves.
This picture shows the individual heart valves. The heart valve openings are protected by flaps of tissue called leaflets or cusps that are attached to the papillary muscles by the chordae tendineae. The papillary muscles are extensions of the heart muscle that pull the cusps together and downward at the onset of ventricular contraction. As the pressure increases in the ventricles, the valves close and the papillary muscles prevent the valves from opening.
Coronary arteries.
The branch of the circulation that supplies oxygen and other nutrients to the cells of the heart is called the coronary circulation. The major coronary arteries are the right coronary artery and the left coronary artery. The left coronary artery originates from a single opening behind the left cusp of the aortic valve and divides into the left anterior descending artery and the circumflex artery. The right coronary artery originates from an opening behind the right cusp of the aortic valve and divides into the three major branches: the conus, the right marginal branch, and the posterior descending branch.
Coronary veins.
After flowing through an extensive network of capillaries, blood from the coronary arteries drain into the cardiac veins. The veins follow into the great cardiac vein and coronary sinus. Blood empties from the coronary sinus into the right atrium.
Cardiac conduction system.
Electrical impulses originate in the sinoatrial node, located at the junction of the right atrium and superior vena cava. Each electrical impulse generated from the SA node travels through the right and left atrium, causing the atria to contract. The impulse then travels to the atrioventricular node, AV node, then to the bundle of His, and finally through the right and left bundle branches of the ventricles, causing the ventricles to contract.
Electrocardiogram.
The P wave of an electrocardiogram represents atrial contraction. The PR interval is a measure of time from the onset of atrial contraction to the onset of ventricular contraction. The QRS complex represents the complete depolarization of the ventricles. The ST segment represents the complete repolarization of the ventricles. Elevation or depression of this segment may indicate heart muscle ischemia. The QT interval represents the complete depolarization and repolarization of the ventricles. A prolonged QT interval is a risk factor for ventricular arrhythmias and sudden death.
Intracardiac pressures.
All right, it starts to get a little deep. Now, I'm going to say, I got to get off of this. Y'all know I messed it up last time. All right, on a scale of 1 to 10, 10 being the worst, who's confused the most? I know. I told y'all it is deep. I thought the video broke it down. I know we went in a little deep about some of the how you get your ST segments and all that, but understanding a little bit of how it goes, you see the picture, how when the heart was firing, where it was coming from, gives you an idea of how the heart and the blood flows. There's not a easy telltale you everything on how to understand this completely. I Trust me, I wish that I could tell you that. Um, Even as a paramedic, sometimes I get confused on now, is that the left side or is that the right atrium? Oh Lord, I had to look it up. So a lot of it is I've taken some things out so it's not as deep and confusing. As you continue your career in EMS, it's going to get a little bit harder if you decide to do advanced and or paramedic. Um, and hopefully you'll continue to do both of those with us, and we can actually get deeper and make it a little bit more clearer than mud if we go that route. So now that y'all are all seeing mud on the same page and seeing how deep it goes, I'm gonna try to keep it going and not be as thick. How about that? Does that make a lot of sense? I know, probably not. All right. So heart-related chest pain usually stems from ischemia, which is such decreased blood flow to the heart. It doesn't have enough oxygen in there. It tells the blood flow is not until the blood flow is restored, your tissue starts dying. So if we don't, you start having chest pain, and then it goes into cardiac issues, and you start not getting enough blood flow there. That's when the heart dies. You start losing percentage. It's the same thing in a cardiac arrest. How long it is before the brain gets oxygen back? Does it start having, you know, you'll start losing percentage of functionality in your brain. So it's the same thing with the heart. And since we only got one heart and one brain, those are very important. We need those to function. So we want to keep blood flowing as much as we can. We want to keep the pressures right. Uh, and make it the blood go round and round. So I know that's like I said, I'm trying my best not to go off. I'm going to badger that name right there. Eriosclerosis is the buildup of which calcium and cholesterol build up from plaque inside the walls. So you see, there it is right there. There's the plaque, and see how narrow the artery breaks down. So you can see back here how really wide it is, and then it starts, that's where your pressure's changing. So there's a lot of buildup of pressure right here, and then it shoots on through. Um, so like it can cause complete occlusion of the blockage. So it's where people go in there and they have balloons put in, fatty material accumulations as a person ages, results in some narrowing of the lumen inside of the arteries. The inner wall of the artery becomes rough and brittle. That's where you see some people will start having to take medication for that. And then you have if the brittle plaque develops a crack for any reason, we don't know why, the raised edge of the crack activates the blood clotting system, resulting in the blood clot that will partially or completely block the lumen of the artery. So this right here is what we're talking about. It can be blocked 100% by this plaque down here. So that's the reason why getting your cardiac output, go to your cardiologist, is very important, because we want to keep the arteries looking like this versus like this. Highly important. So a thrombolism is a blood clot that floats through the blood vessels. We all know about the strokes and how long it takes to get there, when you need to go, how far apart, how fast you need to get to the hospital, all that fun stuff. If it reaches an area that's too narrow for it to pass, it's gonna block it up, and at that point, it's gonna stop. It's gonna do the back pressure. Some tissues downstream from the clot's gonna start suffering from hypoxia. They're not gonna get enough oxygen for them to keep functioning. So now we're starting to cause downstream issues. So then, if it goes too long before it starts getting oxygenated, we're gonna start losing it. That tissue will start dying. This sequence of events is also known as acute myocardial infarction, so AMI or an MI. You may just hear myocardial infarction. It's classic of a heart attack. And infarction means the death of tissue. So now you understand it's a myocardial death of tissue. The death of the heart muscle can severely diminish the heart's ability to pump, and that's going to be a cardiac arrest. So the more, we'll call it AMI, so the acute myocardial infarction, that is not treated and or restored, you're going to have more of a chance to have a cardiac arrest. Coronary artery disease is the leading, I just went blank, is the leading cause of death in the United States. It's for men and women, not just one sex of either. So the peak incidence of heart disease is between 45 and 65 years of age, but it can strike any individual, doesn't matter from a teenager to 90 years old. It don't play, it likes everybody. So some big risk factors of this, cigarette smoking, you got some high untreated blood pressure, that cholesterol gets high, your high sugars, which is your diabetes, you're sitting on your booty, you get lack of exercise, and obesity. So some of the other major uncontrollable factors, you just get older in life, things happen, every day tricks by, we getting older and older. And then you got a family history of cardiac issues. You don't have, that's not noted. If your parents passed away, or your first cousin, and you didn't know that they had those, they just passed. That's the reason why we try to make things happen now. Race, ethnicity, and being a male is a telltale sign. We're gonna have these issues of an AMI over women. Yeah, I know we're special, so don't blame us when your husbands don't go get checked out. We just stubborn. So now you can use that as an example, saying if you don't get checked and all that, you're higher risk of having a myocardial infarction. So ACS is a acute coronary syndrome. We call this, it's called by myocardial ischemia, angina pectoris, and then AMI again. Just trying to read some of the other notes on the side. So angina pectoris, I'm going the wrong way. It occurs when the heart's need for oxygen exceeds the availability supply. It's usually during physical or emotional distress, or during an event. So it can result from a spasm of the artery, but sometimes it's often to a symptom of coronary artery disease. Sorry, I'm having trouble talking tonight, and it is killing me. So it may be triggered by a large meal. Obviously, we know a lot of times these heart attacks and cardiac arrests happen right after a very big meal, and we got to suction every bit of that meal back out. Y'all know it, so it's not like I can hide it. When increased oxygen goes into demand, sorry, I see your message on there. I got to change back over. Oh, Robin, your husband's had 3 strokes. Man, I'm so sorry to hear about that. I hate that. That's bad news. Whew. I feel like we should talk about that. I'm trying to figure out now to get back on topic. I'm sorry. So when increased oxygen demand goes away, the pain normally subsides also. Angina is commonly described as a crushing pain. Feels like somebody's standing on my chest. Cause I can tell you, if somebody's standing on my chest, I'm hoping it's because they are, instead of, angina. So it's usually felt in the mid portion of the chest, right underneath the sternum. Sometimes it can radiate to the jaw, to the arms. A lot of times, 99.9% of the times, it's going to be to the left arm. You may have some complaints of mid back, or epigastrium complaints, maybe like in the center of the abdomen. A lot of times this will only last from like 3 to, I'm gonna say maybe 5 to 8 minutes, but less than 20 minutes and it's gone. It's out of here. So it may be associated with shortness of breath, nausea, or sweating. So, and I can tell you, it's a little telltale time. This is Chris Wally's 101. I'll give my other little facts later on. You go to somebody and they're complaining of chest pain. Does everybody know what I'm talking about when I say the beads of sweat on your forehead? Like the little bitty beads on your sweat. Like if you get outside and work and you got your forehead builds up with sweat. Okay. So to tell the difference between a cardiac or not, those beads will not run if it's cardiac related. Now I don't know why. Don't ask that, please. But I had, yep, you're right, Victoria, that's the Wallyism. Y'all take notes of that. I had the head cardiac surgeon of the Med in Memphis tell me that, and he showed it to me when I brought a patient in one night. And he said, "Here you go." And ever since then, that has stuck with me. And that is a way that you can kind of tell that these signs may be cardiac related or they may not. Now, it is not going to take place in every single person that you come across. And I can also tell you another Wallyism. Black females 65 years and younger will not show signs of chest pains or cardiac dysrhythmias. It's not going to happen. I have had 5 of them that I go and put on 12 leads, and I'm like, "Oh, ma'am, you're having a cardiac, you're having a heart attack right now." Like it shocked you because that's not what you're ready for. So that is not a telltale thing again, I can tell you, but I can promise you the ones that I had, 65 years younger, black females, do not show signs of chest pains. So keep that in your pocket. Maybe you'll use it one day. I'm full of useless knowledge. I apologize. All right, back on topic. So this chest pain, this angina, will disappear promptly after they get some rest, sit them down, prop their feet up. Now, you don't have to put them in Trendelenburg or anything like that, but give them some rest, put them on some oxygen. If you have to, or your agency allows you, you can give nitroglycerin. If they get a headache, it's not cardiac related. If the nitro relieves the pain, what do we need to do with them? Somebody tell me. Load and go. They must be transported. So I always like to tell you folks, get them on the stretcher. Hey, I don't want to go. I just want you to look at me. Okay, well, sit right here on my stretcher and let me look at you. That's why you always walk up and make sure you have everything you need. So even though this angina may not lead to death, but it could lead to permanent heart damage, but it is a big warning sign that these people need to take serious. I always have this thing. It's another Wallyism. Victoria, you got me a new word tonight. The first time is on you. The second time is on me. You get to make the decision on the first time if I can't talk you into going to the hospital. The second time, if I see you again, you must go. And then I'm one of those that I know the addresses. If I go to a house and I can hear it later on in the evening, if I'm on a truck and I hear it, I'll jump a call. And I'm like, nope, I saw you earlier. You need to come with me again. Here's the reason why, because now it's a repetitive thing. So also remember that. You'll remember your addresses in your area. Depends on how your EMS service works. If you stay in an area or you work on system status management, you may rotate. It all just depends. But you'll pick up what I'm putting down, and you'll build a. If it's up to you, you'll build a rapport with some of these people, and you'll come up with your own ways. So now you have unstable and stable angina. Unstable angina occurs in a response to fewer stimuli than ordinary required to produce angina. That's confusing. I don't like that one. So stable angina responds to rest and nitroglycerin. So if I can fix it with oxygen, rest, and nitro, it's stable, which means they are having a chest pains, they are having a cardiac incident, but I'm able to fix it early. If you do all of those things and it doesn't relieve it, you need to hurry up and go. So patients experiencing chest pain or discomfort should always be treated as if they are having an MI. We want to say that they're having a myocardial infarction until advanced life support arrives and or they're taken to a cardiac unit. We can make those determines in the field as paramedics, but it's basics you cannot. That's why I highly encourage you to pass your registry and keep on coming back to us so we can get you ready for paramedic school, because you're going to want to, I promise you. So AMI pain scales signals actual death of the cells in the heart muscle. So it's letting you know that the heart is starting to have issues. They're saying that they feel like they're sitting on their chest. Well, you only got 100% of your heart. I seen you 3 times. You may have 30% knocked off. So once the dead cells, they can't be revived. Tell them, hey man, I can't fix this. They will turn to scar tissue, and they'll be more of a burden as the heart starts beating. So that just let them know it's just like a scar tissue. It's going to get worse. After about 30 minutes of blood flow and it's been cut off, some heart muscles are going to automatically die. You ain't getting them back. After about 2 hours, half of the cells in the area are going to die. Not like maybe, no, they are. In 4 to 6 hours or more, 90% of the cells are dead. Man, that's a lot. Y'all think about that. 90% of the cells in 4 to 6 hours of a cardiac incident are going to be dead. Whew. Open the coronary artery with either a clot buster, a thrombolytic, or an sorry, I was listening to the radio, or angioplast. It may prevent permanent damage if it's done within the first few hours, but it may not. We definitely want to make sure we transport to the essential hospital. That is very, very important. We'll let them know we're coming in with possible MI. They may have the team sitting down there waiting on you. They may take them straight into surgery. It's just one of those things. Load and go. Don't sit around and wait. Make sure that you get them situated and you hurry up. Because if the longer that you wait on this MI, the more that they're going to die. So here's some signs and symptoms of an AMI. You're going to see all of the ones that are written there. Those are some of the telltale signs that we go off of. And then you got a sudden onset of weakness, nausea, and vomiting. Sweating. We talked about what I told you, the Wallyism, and that's just keep that in the back of your mind. You'll have discomfort in the jaw. It'll be in the lower back, the abdomen. I haven't ever seen the neck pain. I'm not gonna rule that out, but irregular heartbeat, or they may just pass out. I think the bottom one, the sudden death, that's kind of obvious, but I don't think we're going to go with that's a sign of an AMI. That's going to be a sign of a cardiac arrest. So your job just got a lot harder. I'm trying to figure out when we can stop. AMI, some of the pain differs from angina. It may or may not be caused by exertion and can occur at any time. Sometimes with a person sitting quietly or even sleeping, it's where you get the ones that pass in their sleep because it was due to a cardiac event. It does not resolve in a few minutes. Sometimes it can last from 30 minutes to a couple of hours. It may not be relieved with nitro. They may have to go something better or worse. Not all patients who are receiving an AMI or who are having an AMI don't recognize it. They don't know that that's what they're doing. So when you get called to the scene and your chief complaint is completely off the wall, but you reach for a radial pulse and you just check it and you're like, this is weird. It's, it doesn't seem like it's right. Complete a thorough assessment no matter what that patient's saying. Make sure you document everything. You do your due diligence to do what's best for that patient. We'll do this slide and the next one, and then we'll take a quick break. All right, some of the physical findings of an AMI and cardiac compromise. You'll show your general appearance. They're going to be scared because they don't know what the hell's going on. Like their heart has never done this, and I feel like crap. I don't want to die. You're probably going to be sick to your stomach. They may see some vomit, and they'll have cold sweats. They'll probably have like 15 blankets on, sitting in front of the heater, and can't figure out why they cold. You'll see that pale, ashy color skin. Cyanosis around the lips is a big thing. Check their pulse, because their pulse rate is going to increase because they're responding to the pain, and then their fear is going to be through the roof. So imagine that. The fear, their stress, their pain, all that's going to create for their pulse to go higher. And what they're doing is they're responding to the myocardium injury. So the issues that's going on with the heart is being damaged, it's being hurt, and that's why their pulse is up, because they're not used to this. Bradycardia. Do y'all know what bradycardia is? I know they may have gone over in that little video real quick. Let's see who's read up. Somebody tell me what bradycardia is. Low heart rate, slow heart rate. Good job, folks. So, and it may, so that's due to the damage. I'm not saying just because you got bradycardia, is not going to be having an AMI. So y'all understand that. But in a cardiac incident, it may be related to damage to the inferior area. So that's where your pulse comes from. So your blood pressure, that's probably going to fall due to some diminished cardiac output, and that's coming from your left ventricle. Let's see. Most AMI patients will have a normal or possibly elevated blood pressure. Their respirations are going to be fine. If the patient has a history of CHF, which is congestive heart failure, they may be rapid and labored, which is their breathing is going to be crazier. It's going to be high, and they're probably going to be a little cyanotic. You may see a little bit of sputy froth. Just depends. Their mental status depends on how far along they are, how long they fought it. You may see a little bit of confusion. I think the agitation that you're going to see is probably going to come from the scared stress. I don't know what's going on. And then you're going to hear it. I think I'm going to die. Never underestimate anybody that says, I think I'm going to die. You might want to hurry up then. I've heard it 5 times in my life, and each one of those have died. So think fast, do what's best, transport your patient. If they say, I think I'm going to die, believe them. Same thing as pregnant women. If they say, the baby's coming, believe them, that baby's coming. So I'm going to leave you on that note. We'll take 10 minutes-ish. See y'all at 7:10. Go get a drink, swallow something, take a pill. Promise you it's going to be okay. I know it's a lot. See y'all back in 10 minutes. All right, it helped if I clicked the right button. All right, is everybody back? We got all 17 people here. I'll give y'all a second to kind of pipe back in and get ready to go. All right. So we'll keep going from here. I'll just tell you, we only got 400 slides more to go. I'm just messing with you. All right, so we're going to have 3 serious, obviously, consequences of an AMI. Pretty sure y'all could have guessed these prior to that. You're going to have death resulting from a cardiac arrest. You're going to have cardiogenic shock, and then CHF. It's kind of our biggest 3. Then we'll go over some dysrhythmias described as an abnormality of the heart. You'll have your premature ventricular contractions, or extra beats in a damaged ventricle. They're harmless and common as among healthy as well as sick people. You have your PVCs, your PJCs, that's probably your easiest one. I know that's, oh, Victoria, yeah, I got till Tuesday. Trust me, I'm well needing that drink. Oh yeah, Tuesday I'm traveling home, folks. Maybe delayed. I got a few things to do. Hopefully I can be on Tuesday night. If not, I'm gonna have to beg Rob to take my place. We'll go. All right. So then you talk about tachycardia. So tachycardia is a high pulse. So it's described as beating of the heart rate of more than 100 times. Bradycardia describes as usually a low one, which we said that again, which is a low of 60 beats a minute. Then you have your ventricular tachycardia is a very rapid heart rate at 150 to 200 beats a minute. So that's moving. So they may deteriorate and they start coming into VFib, which is ventricular fibrillation. VFib is just, oh, sorry, I got confused on my screen. VFib is deorganized, ineffective quivering of the ventricles. When they're in VFib, no blood is pumped through the body, and the patient usually becomes unconscious within a couple of seconds, and then you're gonna have to defibrillate and convert this arrhythmia. So if they go into VFib, you may see it. Your paramedic may be like, "Oh God, they're in VFib." If they don't defib them pretty quick and jump on that, they're gonna be unresponsive. So should be moving pretty fast on that. So defibrillation is a process of shocking the heart with a specialized electrical current to restore normal cardiac rhythms. Hopefully, it does what it's supposed to do. It says right there, it can save lives and shocks are delivered within a few minutes. That's the reason why CPR and fast AED response is what we aim for. It's what we teach. It's what we go out there and push to the public. CPR must be initiated until a defibrillator arrives. You may have some of your dispatchers you've talked to in the past saying CPR has not been started or CPR is started. Just because some people are not okay with doing that. They may be a loved one. It could be, man, it all depends. They may have just found them like that. Chances of survival diminish about 10% each minute until defib is accomplished. So that's a lot. If you think about that, for unknown downtime, and you're thinking 10 minutes and you're like, man, this guy or lady, they not coming back. But you got to do your best. Unless the family states that they don't want anything done. You can look, make sure that there's nothing there, but if they don't want it, you can go that route. So asystole is the absence of is all heart electrical activity, means it's flatlined. It's not like you see on TVs where it goes up, squiggly, like I'm moving my mouse. It's just straight across right there. Just like this little bitty line right there, that's asystole. All right, it usually reflects as a long period of ischemia. Nearly, I'm going to say every single patient in asystole is probably going to die. You may have that 1% chance that you're able to bring somebody back that's been in asystole for a hot minute, but 99% of the chance you need to call somebody else to transport them. All right, so cardiogenic shock occurs when the body's tissue does not get enough oxygen, which is causing your organs to malfunction. You're going to have them shut down. Uh, cardiogenic shocks most of the time going to happen after a heart attack. It's following up from a heart attack. The heart lacks power to force enough blood through the circulatory system, so we're not pumping enough. Well, now the body's in shock and the heart's quivering because it doesn't have enough blood to pump. There may still be some electrical current, maybe, and there's not enough to pump the blood through there. It is more common in an acute myocardial infarction affecting the inferior and posterior regions of the left ventricle. Whew, that's a lot. It is important to recognize shock in its early stage. Now, we're not talking about traumatic shock. We're more right here. We're talking about cardiogenic shock. That is some of the big things that we want to make sure that's there. So it starts right there. It says heart lacks the power to pump, like we just said. Recognize shock in the early stage. We just said we moving right along. So then we talk about CHF, which we have talked a little bit about CHF in the past, just here and there. Yeah, wrong page. So CHF often occurs within the first few days after an MI. CHF develops when increased heart rate and the enlargement of the left ventricle no longer make up the decreased heart functions. And that's due to diseased heart or the valves or just chronic hypertension that's untreated. It's called congestive because the lungs become congested with fluid, and that's a lot of the times it's 99% of it's pulmonary edema. Once the heart fails to pump efficiently, it's done. It's congestive because it's built up over time. Sometimes it does occurs very fast, but most of the time it's over a couple of months. They kind of have a bad history on taking care of things, or due to an MI that now they have CHF. And an acute onset of CHF, you may have pulmonary edema is accompanied by the pink frothy sputum that nobody wants to see. And they'll have severe dyspnea. If y'all remember, we went over that the other night. So they can't even say one word without having to take a deep breath. It's very, very difficult for them to breathe. They're going to be on high flow O2 majority of the time. See this every day. It's not a pretty sight. No, Travis, it's not. It's sad. It's very disheartening. I'm sorry you're having to go through that with in the family. I wish you guys the well. It's very sad. We wish we could fix a lot of things. I lost my mom to cancer, so I despise every ounce of cancer. But that's a different topic, different day. But Travis, I'm sorry you had to deal with that. On edema, you may have it. It's probably collecting some body parts, and depending on the area, like feet and legs are your biggest areas that you're going to see this edema in. So just remember, check their feet. If you got to pull up their pants leg and just tell them, say, hey, look, I just want to check your legs. I want to see how everything's looking, and then don't dig your fingers into their leg, but just do a light press or move their socks down. That's kind of a telltale sign too on how much edema they got sitting there. That's just the easiest thing to do. All right, so hypertensive emergencies. That's where your blood pressure, your top number is higher than 180 millimeters of mercury. You'll have sudden severe headaches, which is a very common sign. You'll have strong bounding pulse. You'll have some, I can't say I've heard ringing of the ears. Hopefully I don't have hypertensive, but that's just what the book's telling you. It's a sign of it. Some other ones, obviously, we'll see here. Nosebleed, I have seen a lot. It's because the blood pressure is so high and the body's trying to compensate. Sudden pulmonary edema, and that may be because of it's such a rapid onset. Dizziness, because their blood pressure is so high that they just can't function. Warm skin, dry, moist. It kind of depends on where you are. I mean, Heck, if it's 98 degrees out there and you're in South Mississippi like I am, you're gonna be warm and dry anyway. So think about that. My ears feel like they have a pulse. It's probably because you're listening to me, Mac. I'm telling you, Mickey. I'm gonna tell you, it's me trying to go over this, and you're going, I don't know what he's saying, and you just have that ringing in your ears too. I bet. I'm just reading those comments. So, Mickey, are you taking anything for your blood pressure, or is that just uh, natural? Yeah, we carry a lot of stuff offshore too. Everybody likes to think that everybody that works in the oil field is big, tough, and all that. No, they not. No, they not. They bunch of babies out here. If I could hand out bows to put in their hair for a bunch of little girls, I would do it. Um, but I take care of my guys very well. We have a lot of blood pressure problems. We keep one medication on board. It's the very easiest to get a hold of, but we can adjust. And I have a chart. If you need it, I have to chart it. You have to come in here twice a day for so many days and all that. Um, I am on a oxy rig. I'm on the Holstein. If anybody knows where that's at, I am in the Green Canyon 645. So you can look it up. We're 150 miles out, so it's pretty deep. Big, strong men are, oh, yep, close to Marco Polo. Are you there where you at, JW? Sorry, we're having a little moment. We bonding here. I'm sorry. It's JW. Speaking of a rig right here by me. No, I do offshore. Oh, okay. Oh, yeah, yeah, yeah. So Marco Polo is to my east. I am 645. I mean, that's what, 2 hour boat ride. You kind of have an idea where we're at. So it's pretty deep. Well, we sit in 5,200 feet of water, if I'm not mistaken. Um, all right, so I'll keep right along. Sorry, folks. I'll read the comments in a minute, Dave. So hypertensive emergencies, if it's untreated, yeah, you can go to a stroke. That's or dissecting aortic aneurysm. I've dealt with two dissecting aortic aneurysms. The first one died on scene, and the second one I felt like I had the most fragile piece of glass ever in my life to hold in my hand, and I was trying to transport it to the hospital because any little bump, twist, turn can make that aneurysm rupture. Um, yeah, I'm gonna tell you, you Mickey was saying I'm in a strong rage when I went to the first doctor. Yeah, I'm gonna tell you, I've dealt with it before. I also had some other issues when I come back from overseas, so I get it. A stroke, um, man, I hate to hear all y'all sick. I'm so sorry to hear all this news, y'all. Um, any kind of untreated hypertensive, y'all, we want to transport them as fast as we can because there's a BLS unit that you're not going to be able to start any fluids or anything like that. So you can help. You don't want to put them in a fluid overload and create more pressure, but you can help with basically it's diluting it a little bit. And you're obviously going to have ALS assistance. Everybody knows when you get to a point like that, even as a basic on a basic truck, if you get somebody that their blood pressure is higher than what? Somebody tell me what that number is higher than to be considered hypertensive. That's correct. Higher than 180. So we're going to need some more assistance from an ALS unit. I've actually seen you guys, somebody saying higher than 150, a doctor is treated for hypertensive. It bounces honestly between which medical doctor deals with them. That's the hard part. All right, so aortic aneurysm is a weakening in the wall of the aortic. It's very, very susceptible to a rupture. If it ruptures, the blood loss can cause the patient to die out immediately. Their blood is going everywhere in their body, and you can't do anything about it. Dissecting aneurysm occurs when the inner layers of the aorta becomes separated, allowing blood to flow at high pressure between the layers. Uncontrolled hypertension is the primary cause. You can have traumatic aortic aneurysm. I've seen it I personally haven't seen it, but I have seen it at a nursing home where a lady fell. They stood her up, and during transport, it ruptured. But when they did the autopsy, they found out that's what it was, and it was just because of a fall. She didn't have any other medical issues, nothing like that. She was in there just because of her age. So, not saying that's the only reason. All right, so on this table in your books on 16-1, this is kind of the AMI versus a dissecting aneurysm. It tells you some of the, like the pain right here, quality of pain. So you'll have tightness of pressure right here, but in an aneurysm, it's going to be a very sharp tear. And they're going to tell you it felt like it was quick and it felt like something tore. And it doesn't, where's that? Sorry, here. Substernal, the back is really, so this right here is back involved, but it's going to be between the shoulder blades. They're going to point, and it's pinpoint. They're like, oh my God, it hurts right here. You'll notice you'll have some issues between each arm of the blood pressure. The pulses are going to be a little different too. And if you suspect this at all, you need to move fast, but go as slow as possible. Fast is smooth, smooth is fast. That really takes place in this situation because any sharp movement that you do, you can actually create it to rupture. And again, there's nothing you can do in the field to fix that. Victoria, sometimes they say flying them and the pressure change. I know we're not going super high in distances and all that, because let's say if it happened out here, it can't. There's no way for them to. Everything has to be flown out here. But they say it sometimes that flying the pressure change can do that. So and depending on where you're at, it may have to go by air, and that's going to be an advanced. Even you'll have your critical care paramedics, your flight paramedics, that'll have that, and they may be able to do a little bit things different because they carry different medications and drugs, so that will help us. Well, all right. So now we're going to talk about aortic aneurysms. Signs and symptoms include very sudden chest pain. It's going to be located in the anterior part of the chest or in the back. Most time you're going to tell them it's right between my shoulder blades. And that's pain that usually comes in full force from 1 minute to the next. So it's kicking their butt. I mean, it's like, oh, God. Okay, it's these stuff. Oh, my God, what is that? That's a lot of times what you'll hear the patient complain of. You'll have some differences in the blood pressure between the arms. You may have a diminished pulse in the lower extremities. So reach down there and be like, I want to make sure I got pedal pulses, radial pulses. If you don't feel it, make sure you note it. I'm real big on carrying Sharpies. For any time that I can feel a pedal pulse, I mark it. I use my Sharpie and I put an X on there. Well, that tells you where I did feel it. And if they can't feel it once they get to the hospital, there's another reason why they say, yeah, I marked it and this is where I felt it initially. And on aortic aneurysms, transport them as fast as possible. I know that's very hard to say that we've only said it, every single time we have a class is transport the patient quickly and safely to their most appropriate facility. And that may be sometimes that we have to, argue with a med control and let them know that they need to go this particular hospital and here's why. All right, going back over our scene size up, primary assessments and all that, being more towards related to cardiac issues. All right, so scene safety is never going to change. We're not going to change that. We always want to make sure the scene is safe. We follow our BSI, which is our standard precautions. Nature of illness. So if dispatch can provide it, let them tell you as much as they can. Look at the scene as you're pulling up on it. Is there family there? And I'm sure there's going to be 900 cars out in the driveway, but they only want them to go because the ambulance gets them there faster. Y'all know, you've all heard that. Talk to your family members, talk to the bystanders, and they may tell you, yeah, normally I've seen Miss Joe outside walking all the time. She's had a, heart surgery about 2 years ago. Telltale sign. you want to form that general impression. Obviously, if they're unresponsive and they're not breathing, start your CPR with chest compressions and call for an AED. Hope to God you at least got an AED on your unit or on your rescue or your fire department. I know some agencies, specifically in Florida, any state-owned vehicle must have an AED on it. I think that's an awesome, awesome thing. And each person that's on that vehicle must have at least CPR certification. At least one person. So even if it's a garbage truck and they're picking up garbage, at least one of the guys on the truck knows CPR. I think that's great. That was signed into legislation several years ago in Florida. Assess the patient's airway and breathing. If it's compromised, fix it. If you notice that on your primary assessment, fix it because that's a life-threatening issue. If the patient has dizziness or they're fainting, has occurred prior to you getting there, you maybe want to think maybe it's respiratory, maybe it's cardiac. So think about those things before you start moving and jerking them up. Maybe they have some spinal issues. Assess their breathing. Determine whether their heart is receiving enough oxygen. Is it because they fainted or passed out because they're not having enough oxygen? Maybe the oxygen that they have at home is out. Currently in the South, everybody's aware that the what is that? I've seen it. The snow occurrence of the century. See, us southern folks don't go on snow mode, so we got to make sure it's really big. If they're out of power or their machine is done, they need something. They're going to have some oxygen deficiency. So help them out. Give them some oxygen. If their saturations or O2 sats are less than 95%, give them high flow O2 at 15 liters. If they can't stand it, give them at least a minimum of 4 liters nasal cannula. So I told y'all both the difference in both of them, so y'all can kind of remember. Just think if they can tolerate it, it's 15 liters. If not, at least let them be put on a nasal cannula and go from there. If they're not breathing or they have inadequate breathing at all, apply 100% oxygen with a bag bowel mask. Think about pulmonary edema. They may need positive pressure or they may need a CPAP. Can somebody remember what CPAP stands for? This is the Jeopardy question right here. I'm not gonna say it's for $100 because I don't have $100. I ain't been paid yet. CPAP. What is the words for CPAP? I know y'all.
Continuous positive airway pressure.
Girl, somebody's Googling quick. Whew. Come on now. I'm proud of y'all. So it is CPAP. It's continuous positive airway pressure. It's up to a certain preset. Depends on your agency. If somebody's at home on CPAP because they sleep that way, that's preset. They don't get to do that. The agency does. Okay, word from the last chapter. Hey, look at y'all. Look at you. I'm very, very proud. I sleep with CPAP. I don't have any problems any of the other times. I just quit breathing about 82 times in an hour, so I had to do something. Otherwise, I was going to pay for another divorce. So I did what I was told to do. But CPAP is very, very beneficial in the EMS world. It helps with the fluid. It displaces it. It gives us positive pressure ventilation, and explain it to your patient. What's about to happen to them? If you as an individual have never had the CPAP mask put on you and you work in an EMS, you need to allow that to happen to you. The reason why I say that is so you can understand, and it's not going to hurt you, but explain it so when you give it to your patient or you're trying to get your patient to take the CPAP, but they're freaking out. You can explain it to them and they'll understand what's going to happen. So now you're able to help them out a lot. And it's very, very simple. It's a wonderful tool. We should have had it many moons ago, but it's very, very good. All right, so we're going to check their circulation. Whew. We're going to check pulse, skin, capillary refill, skin color, moisture, and temperature. Oh, y'all fighting now. Come on now. So consider treatment for cardiogenic shock to reduce the workload of the heart. Because if they're in shock, it's because that their heart's trying to pump so fast to get that blood that's not there. Position the patient in a most comfortable position. Either they're going to be seated up to at least a 45 and or 90 degree, so it helps them feel like they're breathing better. You want to start with your transport decisions as you lay eyes on this patient. Go ahead and get up your transport decision as soon as you lay eyes on this patient is very, very helpful. I'm sorry, I was trying to read something else on the side. All right. Remember, remainder of the assessment can be informed en route to the hospital because we can pause our assessment and continue it because it's a life-threatening issue. Follow your local protocol in determining what facility is most appropriate. If it's the closest, does not make sense, don't take them there. Take them to the one that they need to. You need to determine whether to use the lights and sirens because you're going to make the patient stress out. They're going to freak out, and it's okay to say, "Ma'am, we're going to turn the lights and sirens on because you're that important to us that I want you to get to this facility way faster than anybody else." They don't know you're lying. They don't know that you are just being, "Oh, Jesus, I want this patient out of the back of my truck." It's okay. We know that. We've all been there. As a general rule, patients with cardiac problems should be transported in the most gentle, stress-relieving manner. If I can say that with my calming voice. But don't try to stress that patient out. Try your best to calm them down. Your body, how do I say this? The way that you look is what's going to stress them out. If you look nervous, they're going to freak the hell out because they called you to save them. And now, due to your unpreparedness, it looks like a bag of ass. And excuse me for saying that, because you're there to save them and it's not making them feel no better. So remember, keep your composure and do what's best for them. Yes, you're right. Your eyes say everything. Um, and I know Vicky has talked to y'all and told you that she knows me, but I'm gonna tell you, I'm very honest. I'll tell the patient in a heartbeat, you don't look good, and here's what's fixing to happen. I think that's the way I like to be spoke to. Not sure if some people like that, but I don't want you to see my pucker factor in my face and wonder what's going on. So I'm very open to my patients, and I think that it's good for them to hear it too. So when they get to the hospital, that they're not concerned. Why is there 37 people in my room when I just called because I was having a minor chest pain? It's very easy. It's better to be up front than later on be like, "Sorry, just didn't tell you." All right, so investigate their chief complaint because patients experiencing the AMI, they all gonna have different signs and symptoms. So consider all of the complaints of chest pain. Chris doesn't know how to use his inside face. No, that is very, very correct. Know all your complaints of chest pain. Is it pain or discomfort, shortness of breath, or dizziness? Know all of them. So that'll help you make a better assessment. If the patient is experiencing dyspnea, it is due to the exertion and or related to the patient's position. If you have them seated in the bed and they can't breathe or whatever, sit them up. It's not your house. You ain't got to clean it up. Grab something else and lean them up on it. Say, "Look, we need to get you seated up a little, sit up a little bit. Here, we need to use this." Get them in a better position. If the patient has a cough, I need to know, do they have any sputum? If the patients have any nausea, vomiting, fatigue, headache, or palpitations, do you got COVID? No, I'm just kidding. So I want to know, do you have any chest pains? Has your chest been hurting in the past few days? I need to know that. What is your recent trauma? Has there been any trauma? Uh, Use your sample, your break your sample down and go with some of the, here's some of the following questions I jotted down earlier. Have you ever had a heart attack? Have you been told that you have heart problems? Do you have any risk factors or coronary arteries? Now, people, you got to remember, you got to break that down. You got any heart problems? If you got heart disease, like what? And then you're like, well, maybe not if you don't know what I'm talking about. And then say, hey, what allergies do you have? All right, now, what all medications are you have? Well, then when they hand you the sack full of medications, what are these all prescribed for? Now, I don't need your OTCs. I need your prescription medication. You can take out all the home remedy medications, the oils, the coal, the what is that? The powders. You can take all that stuff out. I don't need that. I need to know what you're prescribed, and then you get like one pill out of the entire bag. Um, Use your OPQRST when you're obtaining the symptoms as part of the sample history. You can start with a sample, and just because they say, "Oh, I've started having chest pains the last day." Okay, so what time did you have those? That's part of your OPQRST, and that breaks it down. Look at this chart right here that's in your book on 16-2. So it talks about your OPQRST when you talk about assessing the chest pain. Here's some of the other thing. Severity. Ask the patient to rate their pain on a pain scale. Some places got this cute little chart. Tell me if it's a smile or a frown. 1 to 10. Bruh. 10 being the worst pain you ever had in your life. Men, it's easy to say, when's the last time you were kicked in the groin? That's a 10. Women, how many times you had a baby? That's 100. So women are better at giving pain scales than men are. I'm speaking from the truth. So ask these questions that's on their level. Don't talk over their heads, talk to their level. Make sure that they feel comfortable and they understand what's going on and they don't have any questions. You want them to be very comfortable. That's all done in your history. So when you're trying to get all this, yeah, you're going to have either a big old piece of tape on you or you're going to have your glove full of everything. But ultimately, once you start with your assessment and you cater it to your way, a lot of these questions will be asked in different ways. You'll have your way, your rhythm, your groove to ask these questions, and you'll write certain things down versus some things you'll be like, I'll remember that. I ain't worried about it. Vital signs, 110% you need to write on your wrist or your hand or your glove, because when you go to give it to the hospital, you'll be like, oh, I don't remember what that first blood pressure was, and then you got to look back on your monitor. So, all right. So now we're going to go over your secondary assessments. What did you find? What was their circulation? What was their the pulses in the various locations? Now I'm not asking you to feel for a femoral pulse every time. Again, we talked about that. But here, assess their pulse. What was their skin color, temp, condition? That's easy. Y'all can pick that up just looking at them and reach down to grab their pulse, and that answers all those. Was their respirations clear? Did it have equal breath sounds? Did they have JVD, which is jugular vein distension? Is the trachea midline, or is it deviated one side to the other? Then you want to write their vital signs down, and not all your vitals, pulse, respiration, and blood pressure. It says in both arms because anytime it's cardiac related, it is very, very, very smart to do it in both arms. I cheat. I like to do the monitor on one arm, and then I do it manual on the other arm. Sometimes I can't hear, but at least once you start taking blood pressures after so long, you know what you're listening for, and you know how your sonographer on your blood pressure, what it looks like, where it starts bouncing. You need to look for those. If you got to continue monitoring their blood pressure, that's fine. Alternate arms, but because you want to get different arm readings. Make sure you do it in the correct intervals. We don't want to stack it on top of each other. And then if you're not able to use like a LifePak 12 or I'm a LifePak fan, so that's all I've used. I'm not a huge fan of Zols. So I know Zols keep the data in there. They can lock them to basic modes and all that. But if you don't have the ability to go in there and reprint your vitals and the machine takes it, make sure you write everything down. It says in here If the patient's having chest pain, it is very valuable to have a 12 lead ran. But again, as basics, we're not allowed to do that. We're going to have to resort to calling ALS. And you may help put the electrodes on, but that is not your job, okay? We don't talk about that. We don't show you how to do that. We just want to make sure that you're up to date on the skills you're supposed to have. All right, so on reassessment, because this is a critical patient, it's a cardiac related patient, it's very important that you assess them every 5 minutes. Look for any signs of change, and if they deteriorate, are they improving, and note that in a report. You want to reassess your vitals, like I said, for every 5 minutes for big changes. If you say, oh crap, the patient's quit breathing, that's a pretty big change. If you get a pulse back, that's a pretty big change, okay? So sudden cardiac arrest is always a risk with the patients experiencing these cardio emergencies. If a cardiac arrest occurs, make sure you got your AED and must use it. If you do have it, make sure you do good CPR. If you don't have it, make sure you do good CPR until your AED gets there. Double check every bit of your interventions. Did the tourniquet hold? Is that why this patient's coded? Because they lost their blood. Did I put the chest seal on correctly because they had a hemopneumo or whatever they come in there? Make sure you do it. Communication and documentation. I add in my report what dispatch advises me versus what I find on scene. That's a habit. I've been to court. I like to document that so I know when I go to court what I was called for versus what I saw. And then if you have to call med control, repeat those orders back to the med control so you understand what they advised you to do. I like to say them out loud and specifically get my partner to hear them. So that way when I'm like, hey, what did med control say again? That now both of you can remember that, okay? That's very important, is documentation of med control. So if they have chest pain or discomfort, make sure your patient's position is also the best thing. Sit them up, loosen their clothes, maybe from the meal that they swollen, and always assess their oxygenation. If their O2 sats are low, give them some oxygen. If they breathe in a whole lot, give them some oxygen. You can use a nasal cannula for these patients, but if they can, it's always best to put them on a non-rebreather. Titrate the oxygen to obtain the best saturations between 95 to 100. Maybe I need to adjust it up or down, just whatever's the best for the patient. And know your limitations on your oxygen delivery devices, because if you drop below a certain number on your BVM, you're going to suck your bags low all the time. And if you up your oxygen on a nasal cannula too high, it's going to look like their nose is being blown to smithereens. So be very cautious with that. On unconscious patients that are breathing, make sure that they're obviously in respiratory distress because something has caused them to go out and you don't want them to quit breathing. So keep an eye on that. You can use a BVM as a positive pressure device like we talked about, but it's whatever your local protocols say that you can do for airway. Know your protocols. Then again, know your protocols. Be prepared to do the aspirin and or prescribed nitro, because right there, if it's the patients, you can assist with it. If they don't have it on them, that is technically given a medication, and you don't have the ability to write that prescription. So remember that. So here's aspirin. We're going to give 81 milligrams chewable tablets. They cannot have water. That's a big thing. It prevents blood clots. We know that. Some people will take those 81 milligrams of chewable tablets. Now you want to give them 324 milligrams, which totals to 4 tablets. On your ambulances, 99% of the ones I've ever worked on in my life carry all 81 milligram tablets. It's the I wish I had them here, but I have them all in individual bags. They're 4 little bitty tablets. A lot of times that you'll see them, they're in orange flavored, so it's easier to chew them up, because if it was regular um, aspirin, it would be very horrible to taste. So you can also provide that. The nitro, it comes in, we talked about this during our pharmacology that I know that I want everybody else head again on. You can have sublingual, which means you want to put this little bitty pill in a gloved hand underneath their tongue. Because if you want to stick it on your bare skin, you'll know it in about 30 seconds how bad your headache's going to be. And then again, we'll do sublingual spray. We can do one spray underneath the tongue, or we can do the transdermal patches. You can do the nitro paste, whatever is in your protocols for your agency. I highly do recommend, once you're at an agency, get their protocols. A lot of it may be tier 2 basics. Paramedics. Sorry, I'm stealing some water. But look at those protocols and ask, hey, I realize that I'm going to be working on a basic truck. Is there a set of basic protocols that I can look at? And a lot of times you'll get, well, it's color coded. Paramedics are in red, basics are in blue. Well, it doesn't say that I can do anything, but make sure you speak to your training officer, your whomever, to go over those what you can and can't do. So here's what nitro is going to do. I know we talked about this before. It's really big. Some of the mechanisms, it's going to relax the blood vessels, so it'll open them. It's going to increase blood flow and oxygen supply to the heart, because during a heart issue, everything's going to dilate. The blood vessels are going to constrict. We want the open blood vessels, so the nitro helps. Basically, it says it relaxes, but it's going to make it from very small to open it up to a workable size, or if not, at least normal. It helps, and I say helps, with the workload of the heart, because it's going to decrease it because of opening the blood vessels. So, Travis, also lowers your BP, so make sure you have them on the monitor. Very, very correct. So we just talked about that one. Sorry, I was thinking about something else, Travis. You got my mind going. Here you're not gonna see that many side effects. The only thing is you will see, like Travis pointed out, you'll have the change of their BP, their pulse rate's gonna change. You may notice that if you got them on a monitor. But the severe headache, I like to say the severe headache is a good thing, because if they do get a headache out of it, it's not cardiac related. So that's one of those other telltale signs that helps you. Here's some other issues that you don't want to give it. If their blood pressure is lower than 100, the head injury, if they've had any sort of head injuries, if they take that magical little blue pill in a 24-hour window and their blood pressure's out the roof, you can't give it. So remember that. It's happened to me more times than any, that I go to take care of somebody and I understand now. I found out why. Let's see, maximum prescribed dose has already been given. So if they give themselves, hey, I've been taking nitro all day long, correct, or any erectile dysfunction, or any erectile drugs that's within 24 to 48 hours. If the patient says, hey, I've been taking nitro all day, well, what's all day to you? I've already taken 4 or 5 pills. You can't give no more. They've had every bit that they can, and it's 100% more than what their doctors have already told them that they can have. So when you go to give this nitro, if it's there, like the patient, make sure it's not expired. It's in the correct container. The containers, if y'all have never seen them, they're little bitty glass jars, got a little white cap on them. They are tinted because they are sun deficient, like the sun will break them down. When you open the container, always have a glove on and pour them into the cap of the bottle. So don't pour them directly into your hand. If there's a lot of powder in the jar, that means that it's old. Be careful about giving that too, because it may or may not work. and always make sure that it's theirs. It's not Joe's from across the room that says, "Oh, he needs nitro. Here, I've got some in my pocket." Nah, cuz we ain't doing that because it's not yours. The patient's. Um, let's see. I'm looking what's next. All right. So we're gonna hit another topic in just a second. I think it's a good time for us to take a break. I gotta get some more water too because I'm out. Let's say see y'all at 8:06 ish. See y'all back in a few minutes. Hey, y'all, give me 5 more minutes. I had somebody walk in real quick.
No problem. All right, that was quicker than I expected. So we don't have that many slides left. We should be able to knock them out in the next few minutes. No, not the next few minutes, but the next little bit, and be kicking off going. All right. So if we're gonna put these people that are having these MIs on a monitor, we need to make sure we put all these leads and the electrodes leads are going to have to be in the same place each individual patient. They've come up through study, and I'm sure trillions of dollars, to figure out exactly where the best positions are going to be. Certain principles are, you want to make sure that there's no hair underneath, that the best skin contact, and you want to minimize artifacts. So artifact is ECG tracing as a result of interference. Any interference that has like the patient's moving or they're shaking their leg, that's all artifact. Um, if the ambulance is very bumpy going up and down the road, that's artifact. We want to minimize that. So that's the reason why we're like, oh, there's a lot of artifact here. We need to clean it up. Well, I mean, you may have to shave the patient. That we just said. There we go. You may have to shave the body hair. You rub the electrodes to the site. So I've seen some places use alcohol. They all use alcohol swab the skin first because it helps draw it out real quick. And make sure you attach the leads to the sticky part prior to poking on the patient because you're gonna push on them. That's gonna hurt. So have them stuck on there and confirm that the appropriate electrode is now attached to the cable and it's placed in its correct placement. It's either the chest or the limb. So here's a picture. So the way Chris Wally, the Wallyism, here you go. White on right, smoke over fire, and the only spot left is green. You figure out what I'm saying? So we're always talking about the patient's left and right. White on right, smoke over fire, green's left. I'm telling you, every time I touch a patient, that's the way I do it. Now this goes over here into a 12 lead. That's way too far for you guys. Y'all shouldn't be even worried about that. But if you look down at the bottom, that's where it breaks down on why it's put there, so it gets the best look at the heart from the fourth intercostal all the way over to the axillary line. But that's really, really deep, and I just wanted to show y'all where the correct placement is. All right, so once the electrode's in place, I turn my monitor on prior, and then I put the strips on individually. So you want to print a little small strip that's basically to check that's a baseline, and then over a few minutes, let it go. So the little strip will kind of tell you if there's any artifact in there,
If there's having any issues, you can fix it prior to, if your medic has to send it over to the hospital, you want to try to clear it up before that happens. So many open heart operations have been performed in the last 30 years. It's probably hundreds and thousands of open heart have been performed. In the coronary artery bypass graft, a blood vessel from the chest or leg is sewn directly to the aorta to the coronary artery beyond the point of obstruction. So they're bypassing it. That's really what it is. It's bypassed of the damaged segment, and that's the reason why we try to do this. Where is the dash? So we can go in there with a tiny little balloon. We can blow it open. The tube is then threaded in the coronary artery and inflated. It's really, really cool. If you ever get the chance to go in there and watch a heart cath, man, that is super cool. Always volunteer to go do that and YouTube it. I know it'll show you some, but actually going physically being in the room and letting them explain things to you, patients awake. They're talking to you. So that's a very educational part there. I've enjoyed it. I've done it multiple times. So patients who have open heart or bypass, Travis, it depends on which hospital you go to. They honestly may not now due to COVID. Everything's restricted because of COVID. But I can tell you in the Jackson metro area, when EMTs and paramedics would go to the trauma center, if there was a cath lab going in, they would always send the student over there to watch because it's super, super cool. So back to this. All right. So patients who have had bypass, sometimes you'll see a scar on their leg, their wrist. So ask, hey, what's the scar from? Just let me know. Always consider their chest pains is legit. Ask, hey, is this the different pain than what you're having before? It's the same pain. Take that is for what it is, because they can have multiple bypasses and they may need multiple bypasses. Look for implanted cardiac pacemakers. You may not always see them in the right place. They may not always be over the left shoulder area, a little bit below the clavicle. I've seen them in belly button or around the belly button areas at the pants line. So ask, what's that right there? What's that bump? What's that on your chest? Tell me how long ago that's been in there. Why is it there? What happened to you prior? Why did you have to have that put in there then? Some cardiac pacemakers. There's really nothing we can do for these. You're just gonna have to transport them to the place. Now, obviously, you can't transport them to the place that they had it done if they did it out of state, but you want to transport to a cardiac center also. But if they did have them done at the same place that's in your area, transport them to there if there's issues. But they're all implanted electrical devices. Basically, it's a AED or that keeps them in a certain rhythm. That's what it's in there for. Here's a sample of one that was put in. There's really nothing you can do as basics. There's no really concern if they say that their pacemaker's acting up. All right, what hospital you gonna go to? That's really all you can look for. Sometimes they may not know right after surgery. You may see some of the malfunctionings that they got to see that they really just put a magnet on top of it, and that's how they send some readings back and forth to that. So it's pretty neat. I've seen them do that in the ER floor. In the ER, they'll come down, place it on there, like, all right, patient's ready to go. Well, that's not really how this works. I can't really do a wait and return. You know what I'm saying? So I've seen them do that before. Heart surgeries and cardiac, automatic implanted cardiac defibrillators. So these are another things that you may see is defibs in the chest. Treat chest pains again with these devices as an MI. Including doing CPR and AED if the patient goes into cardiac arrest. Just because that machine's there, it's just electrical output, but it's just not enough sufficient to mess when you start doing a CPR or shocking the heart. Because at that point, if it's a defibrillator in there, it ain't doing its job. We're having to take over, so that defibrillator failed the patient basically. I've seen these twice. The defib vest are while they're waiting on surgery. They may be put on with the vest and sent home. It does have pads that are attached to the patient. They are kind of restricted to their house because it's a monitor that's also hung by the belt, or they may have to drape it over their shoulders. If they do get shocked, it's going to scare the hell out of you. It's the only way to put it, because it's a 360 shock. I mean, it's a lot of volts running through there. Don't touch the patient. The vest will start talking. Stand clear, and then you're like, sir, just do something, because bam, then it's over. They're gonna get hit. The vest needs, yeah, they do scream because it does hurt, Victoria. You're right. The vest has to stay in place when you're doing CPR. Unless the worst case thing is that if it messes with your compressions, that's the only time you can move it. It is necessary to remove the vest simply to remove the battery from the monitor, and then you remove the vest. So if there's some reason that's in your way for those reasons, but definitely talk to Med Control about that first. Mickey says, my father-in-law had a pacemaker put in, they didn't connect the wire. Oh, wow, that's horrible. I hope he went back and got that fixed. That sounds rough. Yeah, I hope it was a free second time fix. So LVADs are really cool. These devices are usually to enhance the pumping of the left ventricle. Some patients with severe heart failure or in patients who need a temporary boost due to an MI. There's a couple of people in the ambulance service area that I work in that have LVADs, but they're very, 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 very educated about it, and they know how to work it even without the patient. Without being in the facility. Like there it says right there, the patient or the family can tell you more about the device. Take every bit of machinery, take even the paperwork that goes with this thing. You want to look like you moving into the hospital when you walk in with an LVAD. Take all the batteries, because those batteries are specific for that machine. The battery charger is very specific. I'm telling you, grab everything off the shelf, throw it in the truck, and be like, all right, I'm ready to go. Let's do this. Cardiac arrest, we know about that. Due to the complete, there's no more electrical or mechanical or anything going on in the heart. There's no power. So now we're going to have to do that ourselves. You can check for cardiac, carotid pulse, radial pulse. If there is none, it's time to get sweaty. So cardiac arrests are the most always terminal until the advent of CPR. Cardiac arrest was almost always terminal until the advent of CPR and its terminal device in 19. Okay, all right. So back in the days, they didn't have that. So now technology's gotten so much better that we're able to increase the longevity of going into cardiac arrest, because we're able to shock you in a lot of places. The access to AEDs are there. You have your internal and external defibs. So these devices are a lot closer to use, and you're not sitting there like, oh, we got to pronounce another one. You have these tools at your availability, and they're a lot cheaper. Everybody's seen one of these before. You know, they all come in different shapes, forms. We have 3 of them on our platform, besides the life pack that I carry here. We check them once a month. Everything's enclosed, like you see on that little pack right there. Cables, razors, scissors, all that is in a pack. We replace it every 4 years. The battery's good for 2 years. It's just an extra tool to help us as medics out here. If that's on prior to me getting there, all I'm going to do is assist until I'm ready to go. But that machine is way easier to put on them and move versus my big life pack. So most of the time I'll even carry my life pack, but I'll keep the AED on process if they're doing CPR and or shocking, just because of transportation wise. Here's another AED model. All require some operational. They will talk to you. They will tell you what to do as soon as you either pop the lid off or plug them in there, the pads in. and it's most of them are semi-automated, which means they do it all. You will have to push the right here. This is your shock button. So it'll tell you everything right here. It'll tell you stand clear, stand clear. Okay, and then you'll hear the doo. And they won't automatically shock until you're clear and an individual themselves can make sure the patient's clear, so you don't deliver a shock to somebody that doesn't want it or need it. AEDs, we know. I hate to say, but everybody's at least seen an AED. I hope. You don't have to wait on a paramedic to be there. Um, Make sure the pad is appropriate for the patient. Even though it says larger pad or area equals more efficient block shocks. So what they're meaning is you don't want to stack them on top of each other. So if you have an adult pad for a pediatric, it ain't gonna work. Get the pad for the right person so they're far enough apart where they work the best. That's what they're saying. We want to make sure the pads are more appropriate. Here's some of the other things that you can think about is everything's happening at once and you're trying not to have your freak show because this is your first cardiac arrest and I don't know what to do and everybody's looking at you, because that's what's going to happen, I can promise you. I remember my first time as a paramedic, everybody looks at me and I was like, what y'all looking at? Oh, that's right, I am the paramedic. All right, so though all cardiac arrest patients should be analyzed, a lot of them aren't able to be shocked because of the rhythm that they're in. Not all rhythms are shockable. The AED will tell you that. When you analyze the patient, the AEDs will tell you if it's a shockable or non-shockable rhythm. As you see right there, asystole, which is a flat line, indicates that no electrical activity remains, which means you can't shock. I'm going to tell you how to put this. You can't make a dead battery work, even if you tried to recharge it, which that AED is trying to recharge the electrical output into the heart. If there's nothing there, you can't shock it no matter what. So remember that. So that's the thing is AEDs will only shock shockable rhythms. Pulseless electrical activity, which is PEA, it refers to the state of the cardiac arrest that exists despite an organized electrical complex. Transport, transport, transport. Does that make that clear enough? That's really all you can do at that point. Whoop. Sorry, I hit the wrong button. My bad. Is everybody there? I don't know what button I hit. Y'all can hear me? All right, good. Sorry, my screen kind of flickered on my side. So we talk about this. We've preached about this. AHA preaches about this. Early defibrillation is very, very essential for patients experiencing cardiac arrest. The faster we can get that to them, the more. Look, this chart right here makes it better. Y'all have seen this chart before. Recognition and activation of EMS, immediate high-quality CPR, rapid defibrillation, basic and advanced EMS, and ALS and post-arrest care. Those chains of survival have been around. I remember that when I went to basic school. I'm not going to tell you how long ago that was, but I remember going over this particular chain and why it was the utmost important. That's the easiest thing I can tell y'all on cardiac arrest. Go back to there. CPR helps patients in cardiac arrest by prolonging the period during which the defib can be effective. So you're doing the compressions, which is helping the blood pump throughout the body. Rapid defibrillation has successful resuscitated many patients in cardiac arrest due to ventricular fibrillation. Remember, we talked about VFib earlier. Defibrillation works best if it takes place within 2 minutes. And y'all gotta think about that. That's fast. 2 minutes of an onset of cardiac arrest. That's the reason why, man, I love first responders. I love fire guys. I love cops that want to show up. Oh, bruh, everybody here, we finna all get part of this CPR. Let's do it. Non-traditional first responders are even being trained in AEDs. Now some of your EMRs can use AEDs. Man, it's so helpful. That's the reason why I encourage y'all to continue on to paramedic school. I truly believe this field cannot have enough paramedics. We are short. Obviously, we know the nurses are always making more than us. But like I love to joke, in Mississippi, the nursing tags say nurses touch lives. Well, the EMS saves them. We bring them there for y'all to touch them. So paramedics, I will always say they rock the best. Um, the benefits of ALS post arrest is they're able to continue the ventilation for at least 12 breaths a minute, and they can do the entitled CO2. They can make sure that that entitled is about 35 to 40 millimeters of mercury. They can help maintain that oxygen by either they can drop a tube, they can secure that airway, they can help sedate that patient if needed. They can start a line and make sure that blood pressure stays up. If they need to pump more fluid in there, they can flush that fluid in there. Basics, it's one of those. It's hard. If they need to give D50 because their CBG is they're hypoglycemic, they can do that. Basics, you got to make sure that if the patients they can't swallow, we as paramedics we ain't got to worry about that. We just give it to them, start a line and go. It also includes cardiopulmonary and neuro support to the hospital as well as other advanced assessment that can be done by paramedics. And I can tell you, it doesn't matter. The best thing that anybody can do is rapid transport because there's only so much in this world that we can do in the back of that ambulance that is just we're the longer we stay there, the longer we hurt that patient to getting to a physician, to the ER room, to cardiopulmonologist and heart surgery. I mean, just think that the faster we can get there, the better off we are. That's my personal opinion. Now, when we start putting AEDs and CPRs together, it's amazing. The outcome that we're going to have with both of them there is going to work just as fast. Now, even though you're doing CPR, don't stop until the AED has been applied and starts doing and they start analyzing. Don't stop your CPR just because I show up with the monitor. I need you to continue to do CPR, continue to bag that patient, bag valve mask or mouth to mask, not mouth to mouth, but mouth to mask, until I get that those pads on there, and I'm like, all right, step back, let me look. So that's the best time to do it. So your AED maintenance, a lot of these will tell you what's going on, when they need to change the batteries, how often they need to be sent in, or everything's always like they're all enclosed. The batteries are in one unit, the pads are all in a unit. Um, your provider or your fire department or whomever, if it's at a mall, automatically has to do a checklist. They check them out once a month or they turn them on and service them. So your agency, your provider is already going to tell you what you have to do. But if you're out in public, that's not on you. You're just using a tool that's already there. Something else, if you happen to see that there's here they go through the FDA medical, you got to have a MD sign off on it to buy an AED anyway. And as you see there, continuing ed, which you know is once you get out of EMT school, you have to continue Con Ed to keep your EMT basic up. I just renewed mine this year. At 20 years, you get a nice little certificate and plaque. So hopefully after March, I'll get my nice little pretty plaque of 20-year provider. So keep your education up. Always be willing to learn. You don't know everything. Man, I read more and more I can so I can try to give y'all some information. And just because I'm a paramedic doesn't mean I know it all. I text my doctor all the time and be like, hey, man, when you got a minute, you give me a call. I want to ask you about this particular antibiotic and why we've changed to this. It's an education thing, man. It teaches me. It helps me learn. I try to stay on top of things the best as I can. Let's see. All right. So, in preparing for a cardiac arrest, make sure the electrical injures no one. For your okay.
So don't defib if the patient's in water, obviously, and don't defib if somebody's touching the patient, because guess what? Now they fixing to be one of your patients too, because now you got two patients down because the electricity is going to go through them. And always checks the limb, arms, legs, head, torso, that they're not touching any sort of metal too. That's a big one that we don't always ever go over, but we always go over the water and touching somebody else, but the metal's a big part too. If they have a nitro patch on there, you need to clear that. That's why I always say expose the chest in cardiac arrest, because you don't know what's there. They may have that nitro patch or any sort of medication patch on them. I'm not just going to say a nitro patch right here, but if they have any sort of, even a nicotine patch, remove it. Take it off. Use some sort of, even you can use their shirt, a jacket, or something, and dry that area off. If they're hairy, man, female, I don't, whatever you want to call it, I'm not going to be sexist there, but there should be razors in your AED and or your monitor or your bag. You may have to do a dry shave. Yes, we know that's going to be very horrible, but it's either shave their chest or they die. You tell me which one you're going to be better to talk to in front of the patient and or our jury after it's over. Always call for ALS assistance. If you have a tiered system, if you're in a rural area where it's only a BLS transport as fast as you can. Get them to facility after you have done everything you can do, either on scene or on the way to the hospital. That's very, very important. Here's a little algorithm. It's a lot of agencies use algorithms to either go over their protocols and or your duties while working a incident. Y'all can see that one. It just tells you what to do if they're unresponsive, if they do have circulation or not. After you did a certain thing, do the circulation continue? Yes or no? Well, no, you go to the right. If it does say yes, you support ventilations and recheck for pulse. And then it breaks it down. Now, I hope that you don't break this sheet of paper out when you're in the middle of your cardiac arrest. Hopefully you have taken the time to go through an orientation process where they show it to you, you learn it, you go over it, and you sort of know these things, and or when you're sitting around, break them out and read them. Make sure you know them. When you begin chest compressions, if you got an AED close or you brought one with you, attach it as soon as possible. The sooner the better off you are to have that AED in place. Again, I can't preach this enough. Follow your local protocols, whatever your agency has put in place. If the pulse is regained, that's a ROSC, return of spontaneous circulation, ROSC. If it's no pulse and the AED indicates no shock advised, continue CPR. If there's no pulse and there is a shock no pulse regained and the shock is advised, check the patient, make sure they're not touching anything while the machine's charging up. And then I'm going to tell you, once you push that button for the first time you ever pushed, you're like, oh yeah. And then it's really not as big as what you think it is. It's just like, oh, all right, well, all right, back to CPR. So I'm not trying to bust your bubble, but it's going to happen. All right. So if you have to wait for ALS, maybe you're a first responder or you're a BLS provider that your agency says any ALS, any CPR that has started or cardiac arrest, ALS will be en route and you can't transport, wait on them, work on getting there. It says if ALS is not responding to the scene and the protocols agree, begin transport with one of the following. The patient regains a pulse, 6 to 9 shocks are delivered or is directed by protocol. That's kind of the national standard where they go by that. The machine gives 3 consecutive shocks, and they do tell you it's 2 minutes of CPR. And if that no shock is advised or you are directed by a local protocol, continue your CPR until further otherwise. If you've done 10 minutes of CPR and there's been no spontaneous
return of circulation or breath or no ALS providers en route, phone your doctor, phone your med control, give them a story, give them a backstory, and tell them, hey, we've been doing this for 10 to 15 minutes. There's been 0 turns. And if they give you orders to decease CPR, they make sure you follow, like you need their name, what time, what hospital, all that fun stuff. It's a lot. If you're transporting, depends on what your agency's protocols are. If you're in an ambulance and you're transporting and they go into cardiac arrest, you follow your local protocols. Follow them. If it says stop the vehicle, begin CPR, all those right there, follow your protocols. If it does not, you continue your transportation with your person in the back of the ambulance doing CPR. They're just going to have to bounce up and down the road. Hopefully you're careful with them and you're able to transport this patient to the hospital safely with your partner in the back doing this. If the AED is available and the ALS is responding, don't wait on them to say, oh, okay, do this, wait for the paramedics to get there. Man, do your job. That's what you're there for. If you're there because they're having shortness of breath and they go into cardiac arrest, please let the ambulance that's responding know, because that's kind of important too, that they need that. They prepare to make sure they bring everything that they're supposed to in. Don't delay defib. We've said that probably 30 times in the last little bit. When the paramedics arrive, inform them of your actions and what you've been doing to the point of their interaction, and follow. And whatever it says, that after that point, it's up to the paramedic. It's no longer your patient. You don't have to do anything besides assist them. If you have spontaneous return of spontaneous circulation, you want to monitor them, keep them on oxygen. You probably want to keep them on a bag valve mask. Try to do your 10 to 12 breaths a minute. If you're having trouble and you're freaking out and you're tired, you put them on a hooked up with your BVM hooked up to supplemental oxygen, and it'll still blow to them, but you may have to do the forceful ventilation of the bag valve mask. If you're able to see it as a basic, you would love to see their O2 sats between 95 and 100, but not every single time you're going to be able to see that, because your agency may not allow you to carry that in there, or they may just give you a finger pulse probe and you have to go off of that. Again, do your blood pressure every 5 minutes. If possible, rotate between the arms. If ALS is not in your area, follow your local protocols and transport them to the most appropriate facility. Oh, hold on. I'm going to do this real quick. Make sure. Can everybody see me? I know it's a bad picture. I'm really sorry. At least somebody tell me. All right. I know it's a lot. I know it's a lot of information, y'all. A whole bunch. Don't hesitate in letting me know that you need some help. I had a couple of you guys reach out to me about the respiratory part. Don't be afraid to ask for help, because when you don't ask for help and you realize you need help, it's too late. So if you know that you need some help before you sit down and take this test, I'll put my email in the box below, or y'all can message me on Facebook, whichever is easiest to you guys. Y'all let me know early. Again, myself, Rob, y'all met Justin the other night when it was my first night to come on and teach. We can help you guys. This is very, very, between respiratory and cardiology, it's a lot. So that's the reason why I want y'all to see my facial expressions. I understand. I've talked to a couple of you guys on the side and told y'all I'm sorry. I'm trying to slow this down. I'm trying to break it down for you guys so it's easier for y'all to understand. Again, I ask for the sympathy. If y'all have any questions, please ask me and let's go over it. Let's work on this. We can either take it offline or we can continue. And once I pass out the code and the other ones want to drift off, that's fine. If y'all have some particular questions y'all want me to go over, that's great. I see 18 people online tonight. I would like to see 18 people respond to the 4 questions, not a whole bunch, just 4 questions that I posted on Facebook as a pre-homework assignment. Those should be answered by what we went over, and I know that's a lot. Great, Robin. I'm glad. Your mom is a nurse, and she helped to explain it to you. If y'all have any friends, coworkers, associates that do have the education, please ask them. If y'all want to reach out to each other in the class, I think y'all are all on the same Facebook page. So ask away, post a question, let Rob or I tag us, and we'll be more than happy to start open a question. Does anybody have any questions that y'all want to ask? It doesn't matter any part of this cardiology chapter. Please let me know. I will give your code out in just a second, but I'll give y'all 10 or 15 seconds to come up with if y'all have any questions. If not, I'm not going to hold you. I'm trying to find my pad real quick. I'm going to turn my camera off so you don't have to get sick anymore by looking at me. So it's up to you guys to ask questions. If not, I am going to, I got a new email, so I'm having to remember it. So down here in the box that you guys can see, I don't know why it's not typing. That's great. Anyway, let's see if I can do this. I don't know how to do it. Oh well. It won't let me type once I start talking. Hang on, let me try something. Nope, that didn't work either. All right, well, I'll post my email on the Facebook page. If y'all have questions, let's go from there. But I will post your code down here. Oh, I can't type. So, Victoria, do you mind if I message you the code? Will you post it out there for everybody, please? Give me 2 seconds. Let me send this to her, and then I will send it to you guys. I'll say it on here. Once I see her post it, I'll go ahead and talk it also, so y'all know. I gotta ask Rob why that's like that, why I'm not able to chat, why it won't let me. All right, I see Victoria got it. I'm gonna read it out to you guys. It is capital T 49%, as in like the percent sign, little q at, I'm sorry, and, not at, and Q capital L. Yeah, it's all jacked up. I had to come up with something pretty big. I want to make sure y'all are paying attention. You like that, Nicole? All right. So again, capital T 49%, Q, and, the symbol and, Q capital L. I'm gonna keep y'all on your toes. That's the reason why I come up with these wild ones. Y'all gonna have to copy and paste all night long. All right, guys. Look, I'm gonna leave y'all alone. I know I've had y'all for 2 hours and 45 minutes. Y'all are tired. Y'all are bored. Your probably brains are hurting. Yeah, it is a lot, Daryl. I got you. Message me on Facebook if y'all need something. Let me know. I wish y'all the best. I will be traveling Tuesday. Hopefully, I'll be home Tuesday night, and we'll continue on with the next chapter. But please, 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 post some comments on the homework so we can all go from there. Folks, y'all have a good evening. Stay safe, stay warm, and we will see y'all on the next time. Good night.